Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so delighted you could join us. I'd like to continue our discussion that we started last program about eyelid surgery. We spoke at some length about surgery for the upper eyelid, and we tried to distinguish between surgery that is considered to be reconstructive or for medical indications that typically would be covered by insurance, and we try to distinguish from conditions that are purely cosmetic, elective, and not covered by insurance. We started to talk about visual field obstruction. Now that's a very important term, visual field obstruction, which essentially means for a number or any number of reasons, the light or images that are coming in to the eyeball and hitting the retina for some reason are being obstructed. And we talked about different reasons why conditions of the eyelid can create visual field obstruction, and actually outside the eyelid. So just to review, visual field obstruction can be caused by brow ptosis to start. The eyebrow and the fleshy part and the tissue can actually descend so low that it actually interferes with the field of vision. It can interfere with images coming in through the pupil. It can interfere with the amount of light coming in. Again, so brow ptosis can cause visual field obstruction. Lash ptosis is a different phenomena whereby there's so much redundant eyelid skin that the eyelid skin is actually resting upon the eyelashes. Now this can create a feeling of fatigue, especially towards the end of the day. People can have tension headaches. They can feel like their eyes are tired, and they're certainly not tired. But the phenomena comes from dermatochalasia, whereby the eyelids are so heavy or have so much extra skin, the skin is resting on the eyelash, creating lash ptosis. That can also be a condition leading to visual field obstruction. Now, we talked about true ptosis. True ptosis is where the eyelid itself, the lash margin and the lowest part of the upper lid, sits at a point where images or light coming into the eyeball through the pupil actually is obstructed or interfered with. That's called true ptosis. Now that should be distinguished between lash ptosis, as I said. Lash ptosis is where the redundant skin of the upper lid, dermatochalasia, is resting on the lashes, lash ptosis. True ptosis, eyelid ptosis, is when the upper eyelid sits at a position low enough so it interferes with vision, interferes with the amount of light coming in, or images themselves. So true ptosis can have different causes. Some babies can be born with this, that's congenital ptosis. Commonly the levator muscle, the muscle that lifts up the eyelid or elevates the eyelid, is weak or not even non-existent. There can be certain scar contractures, there can be a shortage of tissue, there can be a condition called blepharophimosis, where there's a constricture and a deficiency in the anatomy, and so babies are unable to fully open the eyelid. That's called congenital ptosis. Typically what we would do for that, because their forehead muscle, the frontalis muscle, is working fine, we recreate a sling between the eyelid itself and the working frontalis muscle. And the baby will learn through trial and error, and sometimes with the help of an occupational therapist, the baby will learn that when the baby lifts the eyebrow, that the eyelids will come up. That's because the frontalis muscle is working, and we recreate a sling, sometimes with fascia. Fascia is a kind of a tough, thin, almost like leather tissue that's in the body. The tensor fasciolata on the side of the hip or the side of the thigh, we can often borrow a piece of that to recreate the sling. Sometimes now we'll even take a silastic tube or a silastic artificial fascia to make a sling and connect the eyelid itself to the frontalis muscle. That's called a sling procedure, whereby, again, we connect the upper eyelid that's deficient because the levator muscle is not working well. We connect it to a muscle that is working. So that's one way we correct congenital ptosis. Oftentimes in an adult, we can go in through the anterior approach, in other words, through the skin, and shore up or reattach or imbricate the the levator muscle that has partly detached. Excuse me. The levator muscle in the lid can actually pull away, it can tear away, it can separate, it can become weak, and there's something called the levator aponeurosis. That's the very terminal portion of the levator muscle that attaches to something called the tarsal plate. That's actually a little piece of cartilage. Most people don't know that we have cartilage in the eyelids, but we do. Behind the eyelashes, there's a strip of cartilage called the tarsal plate, and the levator muscle must lift that whole mechanism. So when there's a problem with the levator muscle, we can go in, if there's an anatomic problem with the levator muscle, we can go in and attempt to surgically correct that. That's called a ptosis repair. Commonly, we address the levator muscle or the levator aponeurosis. Now, to distinguish between visual field obstruction, corrective surgery, which is typically covered by insurance, there's medical indications to do that. There are cosmetic reasons why we would operate on the upper eyelid, and most people are familiar with this. Sometimes we will do a brow lift if the brows descend to beyond a certain point. Typically, that we like to see the brows at the level of the orbital rim. Everybody can feel or palpate the orbital rim. You can feel where the eye socket starts at the lower part of the forehead. Typically, we want to see the eyebrow roughly at that area. Now, in women, the attractive eyebrow position typically is with a gentle slope upward, and about at the same level of the corner of the eyelids, we like to see the arch. At that point, the attractive eyelid in the female either goes horizontally or sometimes comes down slightly. But we love to see that peak of the eyebrow just laterally or almost at the side of the eyebrow. So for that reason, in my practice, I do more lateral brow lifts than lift up the entire eyebrow. Sometimes women, sometimes lesser extent men, but sometimes women will need the entire brow lifted, especially when there's heavy and deep wrinkles or ridged at the glabella. Now the glabella is that place between the eyebrows at the top of the nose. That's called the glabella. Sometimes when there's extra skin there, deep folds, furrows, and the brow is low, then I will recommend in my practice a forehead lift or coronal brow lift where we elevate the entire brow or forehead. More often, however, especially in the younger patient, in the female, in the woman, I'll recommend a lateral brow lift because that gives a much more natural, pleasing and aesthetic appearance to have the side or lateral portion of the eyebrow elevated or lifted. That's called a lateral brow lift. Now, it's somewhat different in the male. If we think of many of our famous or better known actors, a low, strong brow is a very masculine, strong, intelligent look. So I do a complete brow lift for men far less often than I will for women. Oftentimes we will sometimes do a brow lift. More often in the male, we'll do a direct brow lift where I make an incision within a forehead crease and we can disguise a scar like that to do a brow lift. So on occasion, I will do a brow lift for a man. However, I think far less often than for a woman. So again, we started with the brow, then we go to the eyelid itself. For the upper eyelid, there's, I would say in general, two components to aesthetic or cosmetic surgery of the eyelid. There can be fat pads, especially towards the nose, near the glabella, towards what we call the middle or medial part of the eyelid. There can be a prominent fat pad there. Sometimes the central part of the eyelid as well can have a fat pad. Laterally, or towards the ear, the fullness, I think, in general is desirable. The lacrimal gland is on the side of the eyelid, closest to the ear, that portion of the eyelid. And of course, I don't really advocate, certainly not removing. I rarely would advocate supporting or rearranging or changing the position of the lacrimal gland because the lacrimal gland is responsible for making tears and it serves a vital purpose. And like I said, it's a good look to have full in the lateral portion of the orbit and the eyelid. So everyone's globe or eyeball is cushioned and lubricated by fat. It's normal. Everyone has fat around the globe or the eyeball. It's held in place by a membrane called a septum, the orbital septum. For some reason in certain families, and sometimes even in younger people in certain families, that membrane or septum becomes weak, and therefore the fat will start to protrude through. That's very common in the lower lid, and in the upper lid it can also give an appearance of a very heavy lid, almost swollen. And of course, this is an area where women will sometimes say, my eyes are so much more swollen in the morning than they are at night. And part of that, of course, is fluid, and part of it is the fluid around the fat. So what do we do to correct that? We can make an incision in the crease. Eyelid scars tend to heal very well, and I can go in and I can remove some of that fat that has undergone what we call pseudo-herniation. In other words, it's pushing through the septum. There are some procedures where I score or strengthen the septum itself. I oftentimes do a combination where I remove some of the fat and strengthen the septum, score it with a little electrocautery, almost like a laser, to strengthen it, and thereby giving a much less full or heavy upper eyelid. Now, another condition can occur, as I said, with dermatochalasia, even before it gets to lash ptosis. Heavy upper eyelids or that extra skin can give a very tired, sometimes down appearance. It can give a person a look that they're not vibrant or even not so active or awake. So most people who have lots of extra eyelid skin are very pleased, or they can be helped quite easily and in a straightforward fashion by upper eyelid blepharoplasty or an eyelid tuck. That's typically a combination of removing some skin. Sometimes I remove a very thin strip of muscle, the orbicularis oculi, and then behind that open the septum, take out some of the fat, the pseudoherniated fat. Sometimes I score that septum, as I said, strengthen it, and then repair step by step, repair each layer. So that's for the upper lid. Again, we're good at correcting some of the heavy appearance of the upper lids by the pseudoherniated fat. And we're also good at taking away some of the extra skin. Typically, the eyelid skin will lose its resilience after being exposed to the sun and with time, and after being exposed to the effects of gravity for some time. Now, typically in the office, we need to examine someone and talk to them, and we can look for brow ptosis. We need to distinguish between eyebrow ptosis and the amount of extra skin of the upper lid. I think that's very important to distinguish, because if we were to do only partly correcting, or if we were to do an operation designed to affect one or the other, and it's really we really need to affect both or the other element, well, of course, that can lead to less than excellent results. So again, we look at the brow, we look at the skin, and we look at the amount of pseudoherniated fat. For the lower lids, typically, there are a number of components we can address. I can begin to talk about that during this segment, and perhaps in our next program we can continue the discussion of the lower lid. For the lower lid, we will typically address the pouches, which again is pseudoherniated fat. Oftentimes, people will feel that they have lots of extra skin of the lower lid, but it's really the fat pouches. Sometimes people have a small amount of extra skin, but I recommend typically very conservative lower blepharoplasty. That's when we take just a very conservative strip of skin right under the lashes and try to disguise that scar. There are a number of ways we can get to the fat pads. One way is called the transconjunctival approach. That's when I go to the inner aspect of the lower lid. I can go through the lining, open the septum, and then gain access to the fat that way. Now, of course, I can gain access to that. That's I can gain access to the three lower compartments, the middle, the central, and the lateral. I can gain access to those fat compartments. However, through that approach, I can't gain access to the skin. So sometimes we'll do a combination approach. At times, I'll do the transconjunctival approach, where I go inside, I sculpt fat from all three compartments, the middle, the central, and the lateral. And then I'll make a separate incision on the outside. Sometimes I do what's called a pinch blepharoplasty. That's where I take a very small, narrow strip of skin. Oftentimes the muscle there, the orbicularis oculi, is also profound, thick, and heavy, and I can also take a very small strip of that muscle, but that's less common because that's important to maintain the integrity of the lid and maintain the position. Next time we have, next segment, I'll be able to talk about a lateral canthoplasty, where we actually affect the position of the lower lid, especially the corner of the eye. Oftentimes, just by elevating the corner of the eye, we can provide a much more youthful, much more cleaner look for the lower lid. So thank you very much for tuning in. I hope you'll come back and we'll finish our discussion about plastic surgery for the lower lid and the upper lid. Once again, this is Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. Thanks so much for joining us. I hope you tune in again very soon. Thanks so much.